Good evening and welcome to the first New York State Vaccine Equity Fireside Chat. Um, my name is Louise Square, and I'm the Health Equity Coordinator for the New York State Department of Health AIDS Institute. Just a quick overview of what our hour will look like. Next slide, please. So we're going to have, which I've already done, a welcome and some housekeeping tips, but you'll get another welcome in just a moment. We're going to have opening remarks, a panel discussion, question and answer, and then closing statements, and a thank you. Next slide. Now I'd like to introduce, our housekeeping rules. To ask a question, please use the Q&A feature. Type your question into this Q&A box and then tap send. Replies will be seen in the Q&A window and may be answered live, out loud, or may be in the Q&A. If you need assistance during the meeting, please contact the training co-host privately through the Zoom chat feature. And now we'll have some opening remarks from our Attorney General, Letitia James.
Good evening, and thank you for joining us for this important discussion. This event is the first in a series of fireside chats we plan to host to complement the work of the New York State Vaccine Equity Task Force. The devastating impact of the COVID-19 pandemic will not be fully measured for years to come. What we do know is that it has magnified the disparities in the state and the nation. The virus has had a disproportionate impact on communities of color. The task force is comprised of trusted community leaders, health professionals, laborers, and others from the state who are working together to implement efforts to not only ensure equitable distribution of vaccines, but instill public confidence in getting vaccinated. We will work to ensure vaccination locations are in places trusted and known by local communities, such as houses of worship, senior centers, community centers, amongst others. There will also be a media and public service announcement strategy, and we plan to join with partners in the ethnic media. On behalf of all task force members, I am incredibly thankful to see so many of you joined us this evening. As many of you know, health experts have projected that in order to win the war against COVID-19, between 75 and 85% of the population needs to receive the vaccine. And as such, New York has made it a top priority to ensure vulnerable and underserved communities are not left behind. This initial talk will focus on building trust, understanding inequities in communities of color, and acknowledging medical distrust, both historically and today. Breaking down the myths, addressing medical distrust, this will be essential to our successful efforts to vaccinate New Yorkers. We hope you find tonight's discussion informative, and we thank our incredible speakers and all of you for your attendance and participation.
So we're going to move right along. I am honored and privileged for this opportunity to have a conversation with such a distinguished panel of doctors who also happen to be women of color, all about inequities that exist in our communities and of color, and about acknowledging the medical mistrust, just as Attorney General said, both historically and today, and all that entails. So first, let me introduce, next slide please, Dr. Oni Blackstock. Dr. Blackstock is the founder and executive director of Health Justice, a consulting practice that provides racial and intersectional equity expertise to health and other organizations. Dr. Blackstock is a primary care and HIV physician and researcher. Her work focuses on HIV, sexual health, and equity. Next, we have Dr. Chinazo Cunningham. You can catch Dr. Cunningham on several media platforms such as The Times, The Washington Post, CNN, NBC, and NPR, discussing her current projects and research. Dr. Cunningham is a professor of medicine and associate chief of the Division of General Medicine at the Albert Einstein School of Medicine. Her research focuses on improving healthcare, access, utilization of health services, and health outcomes around opioid use disorders. And then finally, we have Dr. Aletha Maybank. Dr. Maybank is no stranger to New York public health. As she previously filled the role of Associate Commissioner and later Deputy Commissioner for the New York City Department of Health and Mental Hygiene, where she was an integral in launching the Center for Health Equity. This center was created to strengthen and amplify the department's work in ending health equities across New York City. Dr. Aletha Maybank is the inaugural Chief Health Equity Officer and Group Vice President at the American Medical Association. Her role at the AMA is to embed health equity in all the work of the American Medical Association, and Dr. Maybank is a board certified pediatrician in preventive and public medicine. I'd like to thank you all for being here. During our conversation, we plan to address some of the concerns that have been raised in communities of color regarding vaccination. Our guests are welcome to share their knowledge and experience in the way that they find most helpful. The most important thing we like to come out of this is accurate information that will help our communities make informed decisions. So we only have a short time together with all of you. We're going to jump right into the discussion. Next slide, please. Our first question is, there were many concerns in the public regarding the speed with which the vaccines were developed and approved for emergency use. How can we trust that the appropriate steps were taken to ensure the vaccines are safe and effective? I'm going to open that up to any one of you who want to start.
Sure, I'll get started. Just to say thank you so much for the invitation to be on this panel. Dr. Cunningham actually is a mentor of mine, Dr. Maybank, an esteemed colleague, and just really excited to be here and amazed that so many folks turned out on a Friday evening to listen in on this conversation, which is a really important one. So just so that the audience knows that, all of the phases, phase 1, 2, and 3 of the clinical trials to ensure safety and efficacy were all done. No steps were skipped. And the reason why the timeline was able to be expedited and compressed were because there's several reasons. One is that scientists were able to leverage previous research on related coronaviruses. So SARS and MERS are similar to the novel coronavirus. So that research had been underway since the SARS outbreak in 2003. Some of it was abandoned, but they were able to identify vaccine strategies and targets. They were also able to leverage existing research networks. So the HIV, for instance, Vaccine Trials Network, which has sites throughout the world in many different countries. They were able then to turn those sites into COVID-19 research sites. There also was, many different entities are also developing vaccine candidates. So that allowed for, if one didn't work out, we also had many other candidates that could be potentially viable. And that's very uncommon when vaccines are being developed. Typically, there is maybe 1 or 2 at a time that are developed. And then there was also a huge investment by the US government and the governments of other countries into the development and the production of these vaccines. And so in part, the billions of dollars that were invested allowed for these vaccines to actually be manufactured before their efficacy was proven. And so that actually reduced the financial risk for many of the vaccine production companies, but that allowed for vaccines actually to be ready for distribution once those trials finished. So those are just some of the reasons, and I'm sure my colleagues can also add to what I said.
Yeah, so thanks, Dr. Blackstock, for that opening, and also like an honor to be on this panel. And I am a New Yorker, so it's, I value the context and connection always with New York in many ways. And I'll just add to kind of build on what was saying, and I just want to contextualize that I think the concerns that many folks have, are definitely rational. There was so much misinformation that was out there. It is, a pretty fast time. There are lots of resources, as Dr. Blackstock has laid out, that were put forward to get this done more rapidly. but I just want to acknowledge kind of where people may be sitting, and to say that we get it, and we understand that as healthcare professionals. And as healthcare professionals, we also, most of us have done a really good job at combing through kind of the evidence that has been put forward as it relates to the clinical trials around efficacy and safety. And I think many of us definitely agree that it is safe. We're clear that it is definitely effective. And we needed to be able to do that for ourselves before we're able to really communicate a message to all of you. I think some other just pieces of kind of in the development, when you look at the clinical trials, so those spaces where they test the vaccine out prior to it going to public, for the first time, there was actually a really strong effort to make sure that Black and Brown communities were part of these clinical trials, where oftentimes we've been excluded or left out. We don't have access to that participation. And it wasn't like totally optimal yet, but it was much better than it has been in the past. So at least we can say we were moving towards a better representative population, or a sense that, this is efficacious and again, safe in more populations than just typically the white population that oftentimes these trials get done on. The other important part of safety that I'll just highlight is, in addition to, so the data that has been collected already that we know, and there was a 2-month period that was provided to look to see what would happen with people before the emergency authorization was issued. But in this time, what's going to be very critical is that we still continue to track what happens with people. So there is a tremendous amount of what they call surveillance, or looking at and capturing and collecting data of any side effects that folks may be getting from the vaccine over the next couple, not even just this year, but for years, to really come. And so there's this opportunity to kind of rapidly respond if something were to show up. But for the most part, just based on, usually when they do the trials and you have a new drug or a new vaccine, it usually takes 2 months. Usually within 2 months, you see the most kind of severe effects that may happen. And there weren't many severe effects that were happening, just kind of your typical side effects from getting a vaccine that existed. And so over time and over this year, we will continue to collect this data and see what happens. But I think that's an important part that folks are watching to see what happens.
Yeah, and I would agree with both Dr. Blackstock and Dr. Maybank. And again, I'm really honored to be on this panel with both of them tonight. So I'm a primary care provider in the South Bronx, which got hit extraordinarily hard with COVID. And this is definitely the one question that my patients, really, it comes up all the time is, this is happening so fast. Why is it, happening so fast? Can we trust it? And what I hear is that a lot of my patients say, well, I'll just wait. But I think the issue is, the virus, COVID-19, is not waiting. And so much I'm thinking about what we do in medicine, and it's certainly the same case for COVID-19, is looking at risks and benefits, right? And so we already know the risk. We already know that 40,000 people have died of COVID in New York, right? And hundreds of thousands in the United States. And so, and now we have this amazing benefit. And so what I would say with the vaccine is, just as Dr. Blackstock had mentioned, the building blocks have been in the works for years, right? So looking at mRNA vaccines and also looking at related coronaviruses. And so even though, it might appear to be very fast, the sort of behind the scenes work had been happening for years. I'd also, sort of build again on what Dr. Blackstock mentioned, which was that there's also been unprecedented collaboration. So between countries, scientists in different countries, between the pharmaceutical industry, government, academia, and that's just not we haven't really seen that level of collaboration before, and to really trying to figure out how to solve this problem of COVID-19. And then the other thing that I would just add, and on top of everything that both Dr. Maybank and Blackstock mentioned, was that at the federal level, there's also an additional level of oversight in terms of the data. So it wasn't just the companies, Moderna and Pfizer, looking at their own data, but in fact, the data were also reviewed by an independent panel before deciding sort of if we should move forward. And so sort of all of those levels contributed, to what I would say a vaccine that I certainly trust and that we can trust. And although it appears to have happened so quickly, in fact, the building blocks were in the works for years.
Just to quickly add that I know Dr. Cunningham has gotten both her doses of vaccine. I'm getting my second dose next week. I don't know if Dr. Maybank has gotten hers yet, but just to say that we're also like, some of us have actually gotten the vaccine, so we can speak to that experience.
I got my second dose today. Yes. So I was very excited about that.
Yeah, so for me, so I am not on the front line. I'm doing, policy advocacy work at the national level. So really, I am not yet up to get a vaccine. And I'm, I get asked this, well, you're a physician anyway, but at the same time, like I want to respect the process, and to respect kind of the guidelines that have been put forward for those on the front line to get the vaccine first. However, when my time is ready, I'm ready to get it. I would really value being able to get it, but I'm going to, again, follow the guidelines on who should get this first.
Thank you. Thank you for those responses. I think that's really important. I think I heard you say that basically that there was already some infrastructure in place to help facilitate the acceleration of this production of vaccine, and also that, there were some amazing partnerships that happened to get this done. So thank you for those responses. I think you jumped ahead a little bit because I was going to ask you, as medical providers and as women of color, did you have any concerns or hesitations about personally taking or supporting the vaccine when it came out? So, and if so, how did you overcome them?
So I can say that I was actually, the minute that I found out that I could get the vaccine, I got it. I jumped on it. I didn't hesitate for a second. And I think it really has to do, again, with my personal experience and again, the risk and benefit, balance. So I personally was deployed 3 different times to work in the hospital in the Bronx at Montefiore Medical Center to take care of patients with COVID. I've been a doctor for 22 years at Montefiore. I've worked through the HIV epidemic. Most of my work has focused on opioids, so the overdose epidemic and opioids. So I have seen devastation, but I have never seen anything like COVID-19. And so having been in the hospital, having taken care of patients who were incredibly fearful, who died, whose families and communities, have been destroyed. My own personal sacrifices of not being able to be with my family when I was working in the hospital because I was concerned about giving them the virus, giving my 85-year-old mom the virus. My husband was infected and was hospitalized twice with severe complications. So I have seen this destruction first up close and firsthand. And so for me, the fact that we had a vaccine out that could really protect us, for me was really a no-brainer. I was incredibly grateful. And so as I said, I had my second vaccine today. And I would strongly recommend it to my family. In fact, my mother is in line because she's 85 years old, and also she got her first dose as well. And so for me personally, just again, because I have seen the destruction and nothing else in my whole life has ever compared to that. And a vaccine wouldn't come close to that, even with some side effects. And so it was a clear and simple decision for me.
Thank you, Dr. Cunningham.
Yeah,
Dr. Blackstock?
Yeah, no,
Dr. Maybank?
But no, go ahead, Dr. Blackstock. Go after you.
Okay. Yeah, no, I just want to speak to, I think Dr. Cunningham very vividly described the devastation that she witnessed. I am primarily outpatient, so I was just taking care of patients in the clinic. But spoken with many of my patients who've had family members die, and personally have had neighbors and loved ones either get sick or die from COVID-19. So again, just weighing again the benefits and the risks of it. For me, again, it was something I was like, I'm definitely want to get it. I have to say, maybe on the day that I was going to get it, I was like, okay. I just thought, like, really very briefly, I was like, yikes. But I said, I need to do this. But one interesting thing, the clinic where I work, none of the nurses actually have gotten vaccinated. They're all, have concerns around the safety. Some of them have had COVID-19, some of them were inpatient at some point and were exposed and had COVID-19. And at this point don't find that it's urgent to actually get the vaccinated. Others are very concerned around side effects. So I almost feel like my role, for me, it was actually important to get it as a model, a role model for my colleagues, so that I could speak to what this experience is like, and share it with them. And for me, what's been important in my conversation with them is obviously not to shame. I understand that, as Dr. Cunningham, I think Dr. Maybank also saying that, understandable to have concerns around the side effects and safety, but just really just trying to keep those channels of communication open so that I can answer whatever questions they have or address any concerns. And I do have a sense that over time, as more and more people get vaccinated and people see that it is overall very safe, that hopefully they will also get vaccinated.
Thank you.
And then, for me, to be really quite truthful, before the data came out, I definitely was, to some level, I don't know if it was skeptical or just really waiting for the data to come out to be able to make my decision around whether or not I'm going to get the vaccine. And when it came out, and I'm kind of connected because of the work that I do to these advisory panels and independent panels, pretty intimately through the work that I do, I was able to hear and kind of read over data in different ways, and probably earlier ways than many people, and be in conversation early on also with a lot of experts around the country and leading experts in these spaces. So it was really helpful for me to hear all of that, and then be able to make my decisions actually before it was available. And as soon as I had the understanding of the efficacy and the safety, I was on board to do it. What I will mention and get the vaccine, and as Dr. Blackstock mentioned, the opportunity to role model and to be that messenger is really critical for us, and I think really important for us as women of color and Black women of color. And I will say, it's not only for, and I get the context of patients and other citizens in the country, but it's even for my own family, and so I have family members, I have experienced death, from COVID. Now I kind of I'm really thinking there aren't many of us who have not been connected to somebody personally who has actually passed at this point in time, especially if you identify as Black and Latino. But in addition to that, I have, a cousin who's a nurse, and within the last week or two, we've had this conversation, and she's not, getting the vaccine, she's waiting. And, I have this, desire to say, like, what are you doing? Like, what are you thinking? But the same way that Dr. Blackstock said, we need to approach with empathy, approach with providing the education, what we know, the knowledge was really important for my conversation, even with my own family member. Because I know her influence translates to folks like my mother, who's 84 years old. And so I had to have another conversation with her to kind of really convince her and really tell her the importance of getting this vaccine at this point in time. So she's in New Jersey, so it's a little bit different system than New York, but she is signed up and ready to go. But I think this opportunity for us to be able to model, to be the messenger is absolutely critical for us as Black physicians.
Thank you. I'm just everything that you've said makes perfect sense. I'm just gonna throw a little twist at you. So we know in the past that the government has sanctioned experiments on communities of color, Tuskegee, sterilization of Puerto Rican women, American Indian termination policy. And despite CDC's support for the COVID-19 vaccines, due to historical trauma, many marginalized communities remain hesitant and they're concerned or dismissive regarding the vaccine's effectiveness, the rollout, and emergency use. So what are some steps the medical community is taking to address the legitimate concerns that marginalized communities bring up?
So I'll start with that. I mean, so these are legitimate concerns. Let's just start there, right? I mean, and we in the healthcare system have to earn the trust of our patients and the communities that we serve. So we have to think about the reality of people's lives, what people are dealing with. These are not things that we can learn in a textbook, but it's really through working with our patients and our communities that we can think about how to solve complex problems. And so, what I would say is, we are doing some things. I would say we're not doing enough. So I work in a federally qualified health center, and I think it's important that those federally qualified health centers which serve the underserved really were kind of at the top of the line in terms of handing out vaccines. Mm-hmm. And so that's an important, point that that they're sort of the front of the line as I think as they should be, because they really serve communities of color for the most part, certainly in New York. But I think we need to do better. I think we need to think about, having vaccines available in community-based organizations, community centers, houses of worship. I haven't seen that yet so much. I've heard words, but I think we definitely, the step is to really get out of the healthcare center and get into the communities. And then I think another huge issue is around transparency. So, we pushed hard to get the data out in terms of COVID-19 infections, right? Like who's getting infected and who's getting hospitalized and who's dying. And we saw that, deaths were definitely much higher in Black and Latinx populations. Who's getting vaccinations now? I haven't heard. I don't know. And those are, we have to get those data. And then we need to change our strategy based on those data and the equity, and make sure that that the distribution is equitable. So I'm looking for those data.
Thank you. Dr. Blackstock?
Yeah, no, I totally agree with what Dr. Cunningham said. Yeah, I think, obviously to the point around institutions needing to earn the trust of the community and to show themselves to be trustworthy is incredibly important. And so when you have, for instance, large medical systems that are, giving vaccine to folks who may not be at high risk, these are the types of things that, administrators and things like that, these are the types of things that undermine trust. Creating, saying that the vaccine is going to be available when people show up, it's not available. Like we need to really be able to manage expectations because all of these are all things that erode trust. And so I agree. I think, mobile, we've had mobile testing. I think Alice Sanford's Black Doctors COVID-19 Consortium model in Philadelphia that has gone out into the community and brought services to the people is also going to be doing the same thing when the vaccines become available to her group. I think we need to use models like that. We need to bring this to the communities that are the most impacted. I also think that just on a provider level, I think the conversations that we have with our patients can be really important. A lot of folks don't have primary care providers, but those who do often really actually trust their providers very much. They're actually their most trusted source of information. So for instance, actually yesterday I spoke with one of my patients and I said, well, tell me, what are you thinking about the vaccine? And he said, well, I'm actually worried that it's going to kill me. This is a young man living with HIV. He said I could share his story. He had 3 relatives die from COVID-19, yet he was still more scared of what the vaccine could do to him than what COVID-19 could do to him. And this just made me think about just how deep-seated this inequality-driven mistrust is. But after really like a brief conversation with him, he was like, oh, okay, great, doc. Yeah, I'll take it when it's available. So it's just, so I think, just the messenger really matters. And again, I think Dr. Cunningham spoke to this, like having, imams and, ministers and social workers, like whoever it is, just talking to folks about the vaccine, about the safety and the efficacy is incredibly important and can really help. But again, I think just speaking to what Dr. Cunningham was saying about just institutions needing to do a better job, really engaging with communities. I think that CBOs, faith-based organizations, should be funded to provide the vaccination. A lot of funds are going to large medical centers, and they really should be going to, smaller community-based organizations that are on the front line and have the trust of their communities.
Yeah, I just want to throw a little bit of a twist at Dr. Maybank. Don't get me. But I think, I saw briefly, and it was already in my mind, I saw briefly a question come up about Dr. Susan Moore and how—
That's where I was going to go.
Okay, all right, I'm getting ahead of you. Okay, I'll let you go. Because I think there's some work needed on the provider side, and Dr. Blackstock alluded to that. So I just wanted to throw that out there.
Yes, so, Dr. Susan Moore, and so, is a family medicine physician who was diagnosed with COVID, was being treated for COVID, was hospitalized in the ICU, and received treatment that was definitely unequal. And she recorded it, via Facebook, and posted the video early in December. She was discharged. A whole series of events happened to the point where about 2 weeks later, she actually ended up passing away. And it really demonstrated how our Blackness and brownness definitely, and our level of education as providers does not protect us against racism within the healthcare system. And so, and actually, Dr. Blackstock's sister, Dr. Uche Blackstock, myself, Dr. Kamara Jones, and Dr. Joya Carrera-Perry wrote a piece in the Washington Post just to call out and to say her name, because it's not often that our experiences within the healthcare system are videotaped and shared. And people actually have the opportunity to kind of see and hear the experience. We see that often with police brutality, but it actually clearly exists in the healthcare system, as I'm sure many people have experienced injustice. And so her story and her life really galvanized, again, many of us who have already been kind of doing this work to make sure that, we call this out and that racism still is present. It's not just a historical context, that was mentioned initially in the conversation. This is a present context to how people live and how they experience with the health system. And so I think part of the work in terms of building trust is acknowledging, as we've done, that historical, but also the contemporary context of injustice, not just brushing over it, which I've heard people do in the many places that I've been. I'll just also say, as the AMA, as being at kind of this national level, some of the other work that we're doing, I think, as providers and those who are supporting providers, is really at the advocacy front, and really, we've been doing lots of advocacy with the current administration, but we know the incoming administration definitely has a platform for advancing racial justice, as they've said this. And I think it's going to be imperative that we who have kind of connection and voices to advocacy, that we hold accountability to that commitment to racial justice in the way that everything is done and handled around COVID, from testing to data collection that was already mentioned, but also to the distribution of vaccines across the country. And so I think that's a larger role that we have. In addition, at every level, whether it's at the federal level or the local level or the institutional level, being in public health myself, we plan a lot, right? We put forward plans, we put forward designs on how things should do. And oftentimes the folks who are impacting, or getting the greatest injustice are not part of those planning tables or those conversations. So I think it's one thing where we engage people, sure, but we need to be lots more intentional around that and having shared spaces and sharing power in the development of plans. And not only planning for distribution, but planning for communication around all of this. We need to have equal partners with our community residents around this. And I think this is important to what Dr. Blackstock mentioned as it relates to, the redistribution of funding and resources. That is the core of equity, right? It's the redistribution of power and the redistribution of funding. So when we look at Dr. Ala Stanford, who's doing this work in Philadelphia, we should fund those ideas that are working, and identify more of across the country what has been working, or even across New York State, what has been working, build on those strengths and fund those ideas.
Yeah, and just to also add, I would also say, like, even thinking about like the development of a vaccine, like how equity should be part of that process, like developing vaccines that require like ultra cold storage. Like I understand like this is like an urgent situation, but like, when we're thinking about rural areas, developing countries, urban areas, equity needs to be like incorporated at every single stage of this process, and not just at distribution and communication. It should be all along, and so we end up with situations like this.
Yep. We always, as Dr. Kamara Jones, we have to always be asking ourselves, how as systems and institutions, how is racism operating here? And then what are we going to do about it? And how are we going to hold ourselves accountable? Those are the beginning steps of building trust with communities and people, and it's necessary over time.
Thank you so much. Everything that you said resonates, and that's why these conversations are so important, and we're so grateful you're here. We have just time for maybe one more question. We want to allow time for the audience to ask questions, or for us to get to some of the audience questions. So my last question to you is going to be, I'm gonna pivot a little bit because I could go on with that last conversation for forever. But now that the vaccines are currently being rolled out, is it still important for people to continue to wear masks, social distance, and test for COVID-19 and wash their hands, obviously? And if so, why? Why is it still critically important even after people have been vaccinated?
Yes, the answer is yes. Yes, it's important to wear masks and socially distance and wash our hands and use, sanitizer. I mean, there's several reasons. So, the vaccine is not perfect, right? I mean, no vaccine is perfect. Despite these two vaccines from Pfizer and Moderna are 94 and 95% efficacious. So that's amazing, and that's a lot higher than a lot of other vaccines that we use all the time. But it's not 100%. So that's the first point. But the second point, much bigger, is that it clearly is going to take a long time to get that, the vaccine in every arm that wants it. And so until we reach a level of, 75 to 80, 85% of people in this country vaccinated, we still will have virus transmitted from person to person. So, I don't have a crystal ball to say like at what point we're going to get there, depending on how much, production and distribution, et cetera. But we're obviously a long, long way from that point right now. So those are, really two big issues.
And I'll add to what Dr. Cunningham said too. I think, we know that the vaccine reduces the risk of symptomatic disease from the novel coronavirus. So like when someone has symptoms and gets really sick from it. But we don't yet know definitively whether it actually like prevents infection or transmission, passing it on to other people. It's probably likely that it does, but more follow-up data from the folks who were in the clinical trials is really needed to also to determine whether it also prevents like infection and transmission to other people. So yes, in all of what Dr. Cunningham said.
Thank you. Dr. Maybank, did you want to weigh in before we move to questions?
Not so much. I mean, it's the same. Yes, just to agree that you can't hear it enough, I guess. We need to continue wearing our masks and washing our hands and social distancing, 6 feet apart, and all of those opportunities. I think also, I have several friends actually, who've had COVID, already, and I have 2 of them who've gotten COVID again. And so I really, again, and there's a belief that once they've had it, that they don't need to wear their mask and they're protected. And I just say that we don't know that for sure. And we don't have enough information and data on that. And so again, this is why it's important to still continue with the mask wearing, the 6 feet, social distancing, and the sanitation of, sanitizing of our hands as well. And staying home if you have any symptoms of COVID-19 as well.
Oh yes, that is critically important. Thank you so much. So thank you, ladies. I'm going to turn now to Karen to see if we have any questions, which we have a lot. I know we have a lot. So Karen?
Yes, thank you. And thank you to our wonderful panelists. We do have a number of questions. We're not going to be able to get to all of them this evening, but we will do our best. And at the end of the night, we will share a shared mailbox where you can send your questions, and we'll get you some answers that we're not able to address this evening. So the first one I wanted to ask our panelists is about immigrant communities. One of our attendees shared that they've seen YouTube videos and have heard testimonies from individuals in their home countries, strongly discouraging them from getting the vaccine. So are there any strategies you'd suggest for helping ease concerns that are informed by these videos and some of the worries that members of our immigrant communities might have?
I would say, I think that a lot of it builds on some of the comments that we made earlier about really working with the community and in the community, right? And so thinking about who are the people, the community leaders that are going to be trusted, and working with them. I mean, the other thing that we sort of hadn't really talked about was also the issue around language, right? And so we have to make sure that all of our messaging is, out there and accessible in multiple different languages, also with the media. So, these kinds of discussions, and making sure that they're in the media that are targeting immigrant populations. And so, Spanish speaking, media, et cetera. I mean, I think that those are all critically important. If we just stay in the healthcare world, we're really going to miss this. We have to be out in the communities.
Yeah, I think this is an area where partnership is absolutely critical that we've mentioned before, and partnership in terms of how with the communities themselves, clearly, but with others and with others like media that is geared towards those communities, because oftentimes there are kind of media pipelines that various communities engage with. And I see somebody posted the experience and the community engagement model that we did when I was at the New York City Health Department and was involved with Ebola, as Charles Shorter put that there. And we really capitalized and partnered with the media that really catered towards African communities across New York City, to just do forums because they knew, they understood and they wanted the information, the accurate information, so that they could share it through their various channels so that their communities would get this accurate information. Oftentimes ethnic media really feel a strong sense of obligation and responsibility to their communities to get the accurate information. So I think we have to be very intentional to partner with them. And in a place like New York City, that's tremendously diverse and a lot of media outlets are here. I think we really need to capitalize on that more often. And if we get a chance, I mean, I think the other just community, in addition to the immigrant community, is our people who are incarcerated within New York State and New York City as well, and the need to prioritize and vaccination amongst our citizens in those spaces as well, and not to leave their voices out, and leave them out of whatever plans that also exist. And this is not saying that there should be mandatory vaccine. I'm not saying that they should have the same experience as everyone else in terms of volunteer, but they should be offered priority as well. The data overwhelmingly shows the tremendous impact on people who are incarcerated.
Thank you. Karen, do you want to bring the next question up?
Sure. So how can we help our loved ones with not focusing too heavily on the very minute amounts of severe adverse effects? It really exacerbates the fear, and I'm unsure how to help them.
Yeah, yeah, this is like, yeah, this is a huge issue. I think one thing is for folks to understand why they may have side effects, for instance, like some of the more common side effects, and that actually represents, our body getting ready to fight the infection. So I think we often think, and even just using the word side effects, I think, often has a pejorative or negative association. And I remember there was some alternative term I heard someone use, and I can't remember it right now. But I think it was like response or something like that. But just
reaction.
Understanding that, what did you say?
The reaction.
Oh, reaction, right,
yeah.
right. Reaction, right. Right, and so like, obviously, the soreness, obviously makes sense. But, some of the other sort of more, fever, chills, or achiness that people feel, just really understanding that's actually a good thing. You want that to happen, and because that means that your body is getting ready to protect you in case you encounter the virus. But I think with so many of these conversations, it's probably going to, they're going to be occurring, over time. Unfortunately or fortunately, because of the supply issue, we're going to have lots of time to talk with our loved ones and family members about the vaccine. And I think this just gives an opportunity, hopefully, to, just give folks the information they need to make an informed decision.
And and for us to not give up when, because they're humans as well, and they have every right to say no if they don't want to, and that's what I'm dealing with myself. And I'm here to answer any questions. I bring it up from time to time, just say, hey, how are you doing? Any movement, any thought about the vaccine at this point in time? And I try my best not to push. But I think just providing like the information, as Dr. Blackstock just said, and is going to be, that's what we can do as family members and for our loved ones.
Also, when I talk to my patients too about side effects, again, I go back to risk and benefit. So the side effect, there are side effects of everything in medicine. Every medication we take, even ones that don't require prescriptions, there are side effects. And most of the side effects are mild, right? Headache and soreness and some fatigue. But I also say, what are the side effects of COVID, right? They're huge. And so again, if we're going to look at the risk versus the benefit, I would rather have a side effect from the vaccine than a side effect from the COVID-19 infection itself. The other point that I would make too is, we hear when there are severe reactions, so like the anaphylaxis reaction, right? When some people get hives or and have a severe reaction, but that is really, really rare. It's just that we hear it in the media when it happens. But if you look at the actual numbers, that these sort of severe anaphylactic reactions happen in like 1 out of 100,000 people. If you look at anaphylaxis from penicillin, it's 20 times that, but we don't talk about that, right? And so again, it has to do with the, all of the attention and the sort of media, so that when there is anaphylaxis, we all hear about it. But yet it's much more common with other medications that we've been using for decades.
I think those types of communication points are going to be really critical as we move forward. I think it's such a good point Dr. Cunningham just brought up. Is almost like how to frame the messaging. A lot of our messaging still, I think, kind of follows a typical model of how we communicate around vaccines, or just medicines in general. These are the side effects. These are the, the safety and efficacy of this. These are the percentages. Instead of fully really addressing what the questions are that people have in the gaps. And so this is why this opportunity is really great in these types of town halls and conversations, because we get to see the direct questions, like what really are on people's minds, because there are a lot of assumptions about what people are really thinking, because many folks sometimes that are creating these messages are not directly connected to communities. And I'm not saying all the physicians and the healthcare providers, but they're not necessarily the ones doing the campaigns. the media campaigns and the communication campaigns that are out there. And so, you know, this is like kind of the call to action for those who are like in the health departments and other kind of media entities and some of the collaboratives that have been evolving to put forward communication campaigns to, you know, really make sure that, you know, you take information from like a session like this, or you do more listening sessions to make sure you're really incorporating what reflects where the gaps are in our communities. Again, being at New York City Department of Health, when I was deputy commissioner, when we worked on Ebola, it was through those listening sessions that we were able to really learn a lot about what was really happening and what was the messaging. And in addition to that, we didn't just, so if we drafted something based on that feedback, we then provided the opportunity for the community members to say, okay, that material works, that communication material works, and that communication material doesn't. And so I think we have to be very intentional in that way as well.
Thank you, Dr. Maybank. You took some of the words right out of my mouth. I do think that we haven't done a great job communicating some of the information that's fairly common, or especially around vaccination. Some of what Dr. Cunningham said, some of these things are normal. It happens with every vaccination. And I don't know that we've done a great job of letting folks know that. So thank you for that. I think we have, we don't have time. I was gonna say, we have time for one short question. If folks can limit their responses to like a minute. Karen, you want to give us one more question?
Yes, and we'll see if we can do this quickly. So I think you spoke to this a little bit, but there is a question about kind of, you know, given the speed or the feeling of speed around the vaccine being created and the demographics of individuals, you know, in those studies, what should kind of, you know, community take into account applying those factors to underserved populations? So I think they're trying to get at what should individuals kind of feel about who is part of those studies and that sort of thing. So I think it speaks to the first question of today, but really if you could hone in on moving forward in terms of trusting the vaccine and the science behind it that went into the speed.
So Cunningham did a great job.
So I would say a couple of things. So the number of, in terms of who the participants were in the studies. So, you know, it was disappointing how many people of color were included in the studies. And in fact, in the Pfizer study, the vast majority of the Hispanic participants were not from the US. They were from Latin American countries. So that's disappointing. But, and I think this is what Dr. Maybank, you know, had mentioned earlier, is one of the first things that I did was go to the actual study so that I could see the data for myself. And there were analyses looking by race and ethnicity to see how effective the vaccines were among the different ethnic and racial groups. And so one of the, you know, so the comforting thing was that there was no difference. So it worked similarly well in you know, each of the racial and ethnic groups. So I think from that perspective, that, you know, that's comforting to see, despite the fact that the numbers were small.
Yeah, I agree. And there's just still so much work to do to increase numbers. But I will say, you know, and Kizzy says this a lot, you know, it's better than it was before, but there's a lot more work that has to be done to really have an infrastructure of equity that ensures that Black and Brown voices and people are a part, and bodies are a part of these clinical trials.
Thank you. Dr. Blackstock, did you have anything to add before we wrap up?
No, I just second what Dr. Cunningham and Dr. Maybank said. And just, you know, I think I'm excited to be here with 2 other Black women doctors, but I would love to see in like subsequent fireside chats, having folks who have different roles and positions in the community, so we can hear their voices as well speak on this. I think physicians are also often pushed to the front and like revered, but I know, you know, often when I see patients, they may often tell something to the nurse because they feel more comfortable telling it to the nurse than to me. So just to encourage, you know, a diversity of perspectives and roles when we talk about this issue.
Thank you so much for that. I think that's what's planned for future events, but we definitely hear you and we appreciate that. And I just want to take this moment, first of all, thank you so much. And thank you for making me feel comfortable because, you know, it was so hard not to fan out. I'm a fan of all of you. I've been watching you. I'm a big fan. So I'm honored to have this opportunity to speak with you. And I just wanted to thank you all again for sharing your time and your talents with us. And I'd also like to thank all of you, our participants, for calling in again on a Friday night. This is awesome. And I want to thank you for your thought-provoking questions. I'm so sorry that we weren't able to get to everything, but we did record the chat, so hopefully we can get some answers to you. But I wanted to thank you all. This is the first of our Fireside Chats. We plan to have more, so tune in, and good night, stay safe, and we're going to keep you involved. So let's hashtag vaccinate New York. Thank you. Thanks, everyone.
Good night. Thank you.
Thank you.
Bye-bye.